to talk to us about choosing the right refractive procedure in 2023.
Thank you, sir. A very good morning to all of you. I'll be talking about choosing the right refractive procedure in 2023, that is in current scenario. And in current scenario, we have cornea-based refractive procedures and lens-based refractive procedures. The cornea-based refractive procedures are LASIK, SMILE, surface ablation, and ring segments. Lens-based refractive procedures are phakic implants, refractive lens exchange. We started long back with surface ablation, the first of the procedures, wherein epithelium is debrided and then excimer laser is put, and it results in change in shape of the cornea, and that is how it works. Then came microkeratome LASIK, when a flap was created with the help of a microkeratome, and then once the flap was created, it was lifted, and the stroma is ablated, and that is it. Then came femtosecond LASIK, wherein the flap is created with the help of a femtosecond laser, and rest of the procedure remains the same as a microkeratome LASIK. Lift the flap and go ahead. And then, of course, came the SMILE, which is gaining fast popularity, and wherein instead of ablating the stroma, we just remove a lenticule, the stromal lenticule, and by dissection, and it's all femtosecond procedure. And of course, intracorneal ring segment, which was first approved for low myopia in FDA, wherein it causes an arc shortening effect. We create a track for this ring segment, and then we place it in position. Lens-based refractive procedure can be phakic implants and clear lens or refractive lens exchange. So in clear lens, in phakic implants, the implantable Coulomber lens is the most popular lens that is implanted behind the iris in the sulcus in order to correct for the refractive error, and that's how it corrects the refractive error. So with these things in mind, we first interact with the patient, and the interaction includes what's the motivation, how much is expectations, what is his what's his age, what's the amount of refractive error, whether the refractive error is stable or not. What is the ocular surface? That's again important, because that has a lot of bearing on the outcome of refractive procedure. What's the keratometry? How's the topography and the tomography? And the topography and tomography is basically done to rule out suspicious corneas. So based on placed topography, these are some certain criteria wherein you can detect a suspicious cornea. And based on Scheimpflug photography, we can, based on the curvature map, based on the elevation map, and of course the thickness spatial profile, we can detect suspicious corneas. The PPI max average should be less than 1.2, ART max should be more than 391. And the Bellin-Ambrosia enhanced ectasia display displays the subtle changes that can be seen in early keratoconus. And if you don't find anything, you can also do an anterior segment OCT, which can give you the earliest finding in terms of thinning of epithelium in the inferior and inferior nasal or inferior temporal part. And that is how we detect. And once you are deciding about the how much the ablation you have to do, there is a cutoff of percent tissue altered of 40%. It should be less than 40%. That is flap thickness plus ablation depth divided by central corneal thickness. And the aim for keeping a post-op keratometry should be between 34 to 48, otherwise it will create a lot of aberrations. And of course, the anterior chamber depth, if we are planning for phakic implant, should be good with an open, should be more than 2.8 with an open angle and with an angle recess of more than 35 degrees. So we have these options, and we have to take a decision. As far as ring segment is concerned, it was approved for low myopia, but these days there are better options for low myopia, so we reserve it for post-LASIK ectasias. And also in some cases of primary keratoconus, when the patient is not willing to use contact lens, then some amount of astigmatism can be reduced by ring segments, and then of course you can also place the phakic IOL to correct the remaining refractive error. It also depends on the occupation of the patient. If somebody is in contact sports, then flap-based procedure should be avoided, and we can do smile or surface ablation. So based on the literature, based on all these our own experience, we follow this guideline that if there is a myopia of less than 8 diopters, hyperopia less than 5 diopters, astigmatism less than 4 diopters, and pachymetry enough for RBT more than 300 microns, keratometry between 40 to 46 diopters, and PTA is less than 40%, no evidence of keratoconus, we can go ahead with LASIK or SMILE, anything, microkeratome LASIK or FM2 LASIK. But if the cornea is steep, we should avoid use of microkeratome because it can cause buttonhole. If the cornea is flat, we should again avoid microkeratome because it can cause free cap. And the surface ablation can be done using mitomycin C. And if the RBT is less than 300 microns, if there is large amount of refractive error, in such cases we can use phakic implants. If there's some residual refractive error left after phakic IOL, we can also do a surface ablation or a cornea-based procedure. And definitely last but not the least is an option of a clear lens extraction particularly in patients who are in presbyopic age group. So I'll just show 2-3 case scenarios and I'll conclude. So a 24-year-old male with a refractive error of -4 diopter sphere and -1 diopter cylinder, RSBT 362, 371, residual K is also fine, PTA is less than 40%, maps are all good, no evidence of any keratoconus, we can go ahead and do a cornea-based procedure, LASIK or SMILE. Another scenario, a football player with similar kind of finding, we should better counsel the patient for SMILE if he has come for any refractive procedure. Then, of course, alternative is PRK, which can be done with mitomycin C if you don't have the facility of SMILE. And if another case scenario, 21-year-old male, -9, -10 diopter sphere, RSBT is 236, 221, PTA is high. Even if the map is fine, you should counsel the patient for phakic implant. A 21-year-old male, very high refractive error, 26 diopters, 22 diopters, RSBT, PTA not within normals. Even if the map is okay, you should counsel the patient for bioptics or the Indian phakic implants, the acrylic ones, they can be customized and they can be implanted. And the last scenario, a 55-year-old male with -10 diopter sphere and 2 diopter cylinder. Endo SCD is also less, it is 2.5. Can't put a phakic implant. In such cases, you can, if the patient is willing for it, you can counsel the patient for a refractive lens exchange if the patient is motivated. So in conclusion, refractive surgery to date is not just a cosmetic surgery because heavy dependence on glasses reduces your quality of life. And in order to improve quality of life, refractive surgery has to be done. Like somebody who is having a 10 diopter, 12 diopter of myopia, his quality of life is very much compromised. So in such cases, it's not just a cosmetic, rather it's a therapeutic procedure in order to improve the quality of life. But patient evaluation and understanding the fitness of a patient is most important. And decision not only depends on the parameters, but it also depends on the demand and the occupation of the patient. So thank you very much for your patient listening.
Thank you, Rajesh. Are there any questions from the audience, or would the panel like to speak to Rajesh?
Yeah, I think it's very important to select the right procedure, and pre-op selection of the right procedure for the right patient is very important. Sure. I think assessment in refractive surgery plays a bigger role than doing the actual procedure, and that's why it's a very